Thank you, Noel, and thank you all the speakers. I think the stage is set for the further discussions. When we have discussed the unmet needs in rural areas, and then a possible solution may be emerging from there in form of GILs. So Dr. Ganraj talked about briefly about GILs, and there are many questions still unanswered about whether it is effective, whether it's cost effective, whether there's a formal training program available around it or not, and what is lying in future. So to answer these questions, we have the session 2, where we have set of 4 speakers who have been working on gasless device over more than 2 years now, and they will be taking you through those answers. So the speakers would be first would be Dr. Lavneesh Bains, who is an associate professor of surgery at Maulana Azhar Medical College, a very avid researcher, great interest in finding research-oriented answers, and is one of the leading members of the core team of Project GILS. He will be talking about the various evidence which the literature has provided or which the team has worked on. Then Ms. Brownie Dawkins, health economics expert of the team, she will be talking about the cost effectiveness of this system and her experience about it. Then our own Noel will take you through the training programs around gasless training and gasless laparoscopic surgery. And then at the end, Peter will talk about how the team has been modifying the device and what is there in store for us in future. So straight away, I think we'll go to Dr. Lavneesh. Dr. Lavneesh, over to you.
Thank you, Dr. Anurag. I'm just waiting for the screen share to me. I hope my screen is visible.
Yes, it is visible. You can start.
Okay, fantastic. And very good evening and namaskar from India, Dr. Lavneesh, and Dr. Anurag has kindly already introduced me. I will just take you through few of the slides that how the evidence for GILS has shaped up in the last 3 decades, and I will give you some data regarding that. If you see this gentleman, I think he needs no introduction. He did the first laparoscopic cholecystectomy, but only very few know that he did first initial 6 cases with the gas pneumoperitoneum, and rest of 88 patients out of a series of 94 were done without pneumoperitoneum. And he used this device. It was termed as a galloscope by him. So I think, gasless started a way long back when he did the first surgery started. So gasless, when the laparoscopy was evolving, we used to get any kind of abdominal wall lifting devices. Now these were, subcutaneous devices, intra-abdominal devices. But if you see the picture, the devices seems to be a bit cumbersome. They were difficult to mount, and they were traumatic. If you see all these kind of devices, so they are, additional trauma to the patient. So over the years, the GILS, this abdominal wall lifting devices, they have improved. This is laprofan, this is the laprolift, and this is our own stand positioner. So I will be sharing now a few studies. Say one of the earliest studies which were done in 1995, around 50 patients. So yes, the technique said it is practical, but since the devices were I've shown you the pictures, so there was sufficient for surgery, but not an optimal exposure. And a seizure safety profile was available. This particular study by Nande et al., this was done, published in 2002, but this was done in, Dr. Ganraj has already shown us the Shirikanta device. So they did this with the help of Shirikanta device. And this was done for 5 years, retrospective data. If you see, they concluded that is safe, feasible, and effective alternative. You see, between the 2 groups, they had no major complications and just 6% conversions. So they have already given us an insight that it could be useful in developing countries. Then came this British Journal of Anesthesia. This was more regarding the post-operative scenario with the GILS device. Say in both the groups, pain was nearly same. It leads to early extubation. It's a minimal post-operative nausea, vomiting, and almost no shoulder pain at all. Then started coming, the more evidence, more data, and properly conducted studies in the form of, RCTs. And what they found was that the duration of surgery, steps involved, hospital stay, post-operative pain, everything was comparable. And however, they found that the relief of pain and return to normal activities that was a bit shorter in the gasless. But still, till 2001, see, there is still the exposure was a kind of suboptimal. Most studies, laparoscopic appendicectomy, yes, it was very much comparable, safe and feasible in well-selected patients. And when they started coming to the cost, now this was the time when the cost started coming into the picture, significantly reduced hospital costs, significantly also reduced the need for post-operative analgesia. I will say this particular statement or conclusion by Cochrane Library in their systemic reviews about all the various kind of abdominal wall lifting which was going on. No significant differences in serious adverse event. Yet the operating time was lower in the abdominal wall lift because of the time needed in mounting. But at that particular point of time, the safety of abdominal wall lift device was not particularly established. I will say this particular study, and we started moving on to some kind of a watershed pen was there. Whatever we had studied, they were a bit kind of a low quality. We started moving to high quality studies. And this was the first meta-analysis in 2014 from China. If you see, the surgery duration was bit more in the gasless group. Rest all of those parameters, there were low incidence of postoperative pain, low cost, early return to activity, and less shoulder pain. 791 patients, results were equivocal and comparable. And this particular meta-analysis, it was not just limited to, laparoscopy cholecystectomy. People have tried colorectal surgeries, people have done splenectomy also. Another meta-analysis in the subsequent year, this was only limited to cholecystectomy. Now the things have started changing. You see, the technique provided satisfactory post-op intraoperative field, and the access was much easier. This was perhaps a time people started getting more innovative, getting less traumatic devices, and went on. And this definitely this particular device, which was invented and innovated and modified by Dr. Ganraj, it found a mention in WHO compendium that single incision gasless laparoscopic surgical device can be an innovative health technology for low resource setting. Here comes, Dr. Ganraj has already talked about this. This was our study. We had around 100 patients. What we found was every result, everything which was there already was absolutely comparable. Intraoperative vital parameters, since carbon dioxide was not used, they were much stable, much better, and our anesthetic friends were very happy that monitoring was less required. One important thing that we were also new to the gasless wheels at that time. And initially we had few hiccups, but as soon our experience, we gained more experience, our satisfaction score started improving. And it improved very nicely. Here comes one of the largest study, and this is one of the largest meta-analysis conducted on the gasless by Noyle himself. And it has 63 studies, 41 RCTs, 22 non-RCTs, more than 3,600 patients, including general surgery and gynae procedure. One good thing was it was one of the largest, and it compared gasless with conventional and also gasless with open. When it was compared gasless with convention, you see every parameter is almost same, similar sort of complication, no differences at all. Operative times were just slightly higher in the gasless general surgical group, but they were definitely less in the gynae procedure. When you compare gasless with open surgery, there was slightly higher risk of intraoperative complication, but this was not statistically significant. But the operative time in the gasless group was definitely less. So this is what the evidence has, how it has been evolving. We have moved on from low quality to high quality to various kind of meta-analysis. I see a renewed interest in gasless. Dr. Ganraj has already projected, and this device is under evaluation by Duke University, USA. And we will have to wait how it goes into the clinical studies and clinical trial. And Dr. Mora has shown this particular study, and I also picked a few lines from that study. And in this particular study, he talked about what was the various drawbacks or obstructions for laparoscopy. I picked up the other point that I see 93% yes are interested in increasing the use of laparoscopy, and they were very happy to get a kind of low-cost laparoscopy or a lift retractor device to increase the use of laparoscopy. I will just conclude my messages as for this evidence, GILS is comparable non-inferior. Newer devices offer better exposure. There is a better hemodynamic stability, and many of the lower abdominal procedures can be done under regional anesthesia. It's safe and can be easily done. And with the help of this, we can definitely see for the goal of safe and affordable surgical procedures for all. And that is a motto of global surgery. Thank you. And I had to rush in through the slides because I had to present a few glimpses to you all. Thank you.
Thank you, Dr. Lavneesh. Thank you for very lucid and very nicely you presented all the evidence, and thank you very much. Now, moving ahead, I will invite Ms. Priani for her presentation. Your slides are visible?
Yeah, I'm just going to, there, presenter. I think that's clearer, right?
Yes.
Okay. Hi, everyone. My name is Bryony Dawkins. I'm a health economist, and I'm based at the Academic Unit of Health Economics at the University of Leeds. And I'm here to talk a little bit about some research that we've undertaken as part of the NIHR-funded Global Health Research Group in Surgical Technologies to evaluate the use of gasless laparoscopy as a means to improve access to minimally invasive surgery for patients with abdominal conditions in rural regions of Northeast India. So as we've heard already, when abdominal surgery is required, this can be performed as open surgery, meaning a large incision is made to open up the abdomen, or in many cases it can be performed laparoscopically, meaning small incisions are made through which cameras and specialized surgical equipment are inserted to perform the surgery. Now both can be safe and effective, but laparoscopy is less invasive for patients and recovery time is much faster. And as such, laparoscopic surgery is preferred to open surgery for many conditions. However, laparoscopic surgery requires a reliable CO2 supply, which is used to inflate the abdomen and provide the working space for the surgeon to operate. Now, in rural regions of Northeast India, laparoscopic surgery is not widely available due to the lack of surgical expertise, limited equipment, irregular supply of CO2, and shortage of anaesthetists. And so the majority of abdominal surgeries in this region are performed as open surgery. So these are lots of the problems that we've already heard from our surgeons earlier on. Now, one potential solution to this is providing laparoscopic surgery using a gasless technique, which uses a mechanical device to lift the abdominal wall and create the working space for the surgery, negating the need for CO2 and meaning regular surgical instruments can be used. This type of surgery is still minimally invasive, using small incisions and allowing faster recovery for patients than open surgery. And however, while it's been proven safe and effective, there is limited data. And before our studies, it had not previously been evaluated in a rural Indian setting. So as such, following a training program in gasless laparoscopic surgery, the target study, which we've heard a little bit about already, and using data from a subsequent registry of abdominal operations in rural India, a facility survey, and evidence from the literature obtained through a systematic review, primarily the one that you've just seen in the previous presentation that Noel and the team undertook. We developed a decision tree model to evaluate the cost effectiveness of gasless laparoscopy to increase access to minimally invasive surgery for abdominal conditions in rural Northeast India. So to do that, we evaluated costs from a patient perspective, as healthcare is primarily paid for out of pocket in this setting. And we included direct and indirect costs within our analysis. In terms of outcomes, outcomes were estimated in terms of disability adjusted life years averted, or DALYs averted, which we modelled based on patient severity and duration of symptoms, obtained by expert elicitation. And we also conducted scale-up analysis to model the impact on costs and outcomes as the provision of gasless laparoscopy increases, thus increasing the availability of minimally invasive surgery for abdominal conditions. And we based this analysis on data from 12 facilities in rural Northeast India, which provided the baseline levels of surgical provision. So what we found, so our cost effectiveness analysis showed that based on current evidence, minimally invasive surgery performed as gasless or conventional laparoscopy is less costly and produces better outcomes or less DALYs than open surgery. We compared results to a range of cost effectiveness thresholds and have included those which represent plausible thresholds for India, which we identified from the literature on the cost effectiveness plane here, shown by different coloured lines on the graph. And this shows that even for the lowest plausible threshold that we identified, minimally invasive surgery performed as gasless or conventional laparoscopy is likely to be a cost-effective alternative to open surgery in rural Northeast India. In addition, the scale-up analysis that we undertook indicated that by scaling up the provision of gasless laparoscopy, 64% of DALYs related to abdominal surgery could be averted, which within the 12 facilities that we based our analysis on alone in rural Northeast India, that equates to around 455 additional DALYs averted. So I know that this was a very quick summary because time is scarce, but some conclusions. Our research has shown that gasless laparoscopy is likely to be a cost-effective alternative to open surgery for abdominal conditions in rural Northeast India. Scale up of gasless laparoscopy as a means to increase access to minimally invasive surgery for abdominal conditions would reduce the cost burden to patients and increase the number of DALYs averted. And as such, it can provide a possible bridge to the adoption of full laparoscopic services in resource-limited settings. Very brief, I know, but thank you very much.
Thank you, Briony. And I think most of the surgeons do care about cost effectiveness, but don't know how to measure it very much. Thank you for making it simpler to us. And moving ahead, we'll invite Noel for his presentation on training modules, which we have been using for GILS. Yeah, we can see your slides, Noel. Go ahead.
Thanks very much, Anurag, and thanks, Barney, for that excellent presentation on the cost effectiveness. So I'm going to talk about the gasless laparoscopy training and setting up the registry very, very briefly in the next few minutes. So just want to introduce you to our group. As you can see, we are part of the Global Health Research Group, Surgical Technologies, which was established back in 2017. And we partnered with the rural Northeast India. All the surgeons that are sat in the front row are the rural surgeons that have been part of the target training program. So how did we set up our projects? They were matched with the Lancet global surgery indicators in view to improve and increase especially surgical workforce density, as something that was alluded to by Dr. Gunraj in his slides. To understand the surgical volume, we decided to implement the registry following the training of the rural surgeons. Health economic model you've heard from Briony today, and the acceptability and feasibility studies are currently ongoing as part of the implementation research. So many of these things have been already covered in our first presentations by Dr. Biju and Dr. Elijah. And this was a systematic review done by one of my BSc students, Ellen, and looking at what are the current barriers in the LMIC with regards to laparoscopic surgery. And as you can see, it's a systematic approach and willingness to train, but also the lack of laparoscopic trainers, no curricula, and the big one is the funding to to increase access to training to the rural surgeons. So we feel that in rural surgery, technological advances and low-cost solutions will help the implementation of laparoscopic training, and that's where gasless laparoscopy comes in the picture. She then did a qualitative study with our rural surgeons in Northeast India, again understanding about what are the barriers and facilitators. Again, barriers were very similar to what has been seen in the literature, as well as what was mentioned today. And it was felt that a structured training program, a formal qualification, certification, and standardization of a laparoscopic training program for rural surgeons was essential. So the rural surgeons were handpicked, let's say, from these different areas of Northeast India by Dr. Ganaraj, and were invited into the target training program. So how did we do the target training program? It was divided into 2 different stages, and this happened in March 2019 at Kolkata Medical College. We wanted to use the best training program that was out there, and we felt that fundamentals of laparoscopic surgery, which is a mandatory training program for American surgeons, was implemented, and a lot of support from the American College of Surgeons and SAGES to use that didactic training program, as well as some of the material that could be used for training and implementation. We used different objective assessments for the laparoscopic simulation, as well as during the live operating, we used the OSAT scores and GOAL score to look at their surgical skills in setting up the device and inserting the device, as well as their laparoscopic skills when they are performing a diagnostic laparoscopy on a real patient. So these are some of the pictures where you can see that the surgeons are being trained and assessed formally by trained laparoscopic surgeons both in India and the UK. These were the 5 tasks. We were very specific what tasks they have to perform. And again, they were all based on the fundamental of laparoscopic surgery skills. The first one is the peg transfer on the left, and the precision cutting of a circle, inserting an endo loop on an appendix, and then intracorporeal and extracorporeal knot tying. Again, a very, very advanced laparoscopic skills that our rural surgeons learned. Over here, a quick line graph which breaks down pre and post scores for all those tasks. And as you can see, for majority of the tasks, before the training and after the training, during this 3-day training program, there was a gradual increase in their scores. This paper was published in the International Journal of Surgery by our group, and I welcome everyone to go and have a look at it. But this is a brief summary over here. We almost had 1-to-1 trainee-trainers ratio. Most of the trainers, as you can see, were from India, from tertiary hospitals. The MISTER score, there was an increase from 386 to 524. And you can see their OSAT scores and GOAL score. Although they were not extremely high, but they were comparable with the scores that were achieved in similar settings in other studies. Over here, you can see the cost of the training that was involved, part of this target training program. And I think as you can see, around $300 to $400 per trainee and trainer is something that for a 3-day training program was thought to be fairly cost effective. So what happened next? After the surgeons received a training in a tertiary hospital in Kolkata, the people who were involved in the training, the proctors, went over to their hospitals and trained them in gasless laparoscopy, where the rural surgeons performed the procedure from start to finish, and they were trained, really hands-on training. And this happened for over 2 days in 2 different units of Northeast India. Over here, you can see them in action, actually performing a gasless laparoscopy procedure. And you can see Dr. Biju over there with his staff. And following the training, the rural surgeons then were enrolled into this registry, which was created on the REDCap, database, and all the procedures that they performed were included in this registry. Over here, you can see that 123 gasless procedures were performed over the 9-month period. And as you can see, most of it was affected because of the pandemic, where there was some limitation how many procedures that they could perform. And still, in spite of the pandemic, they were able to perform quite a lot of procedures. The mean setup time, as you can see, is only 7 minutes. The conversion rate, there was no was overall 20%. About 11% was converted to open, and 9% was converted to conventional laparoscopy, which I don't think is a bad number. Usually, the conversion rate in high-income countries is about 5%. The mild to moderate complications were about 5%, which included post-op infection, hematoma, but apart from no other major complications, intraoperative complications. There was one death that was recorded post-operative cholecystectomy. The patients had an MRCP, which did show that they had a clear duct, but unfortunately, this patient passed away with pancreatitis. The mean length of stay for these patients was 3 days. If you look at the conversion, the reasons for conversion, I missed that point. Most of it was due to adhesions, intra-abdominal adhesions, and other was just unable to secure a good view to continue with the surgery. So over here, just a few graphs that I wanted to show you. There's the length of stay amongst all these 123 patients. It's about the median, which is a red dot, is about 3. You may want to ask, like, how much did the patients pay for treatment? There were a combination of hospitals. There were some private hospitals and there were some government hospitals. As you can see, for the procedure itself, the cost, the patients paid between 7,000 rupees, which is about $100, to 21,000, which is $300. And the overall hospital stay was somewhere between 7,000 rupees to more than 25,000 rupees. So in conclusion, it was essential to establish a structured training program based on the evidence, and establishing a national registry was essential. So the registry that is now used in Northeast India has now been implemented nationally across India and led by Maulana Azad Medical College to look at the safety and clinical outcomes of gasless laparoscopy in both urban and rural setting. International collaboration is essential because just focusing on the device itself is not enough. I think there are several other factors that are essential for the implementation of gasless laparoscopy, including a successful training program. Research, training, and infrastructure support is essential, and funding is required for that. Patient-reported outcome measures are also something that is essential for global surgery, rural surgery, and something that would be on the research agenda in the future. I'll end there my presentation. Thank you very much for this opportunity.
Thank you, Noel, for an excellent presentation there. And there are already some chats going on. I think we'll take it after Pete's presentation. Pete, over to you. I think future is looking very good, and I'm sure Pete is going to highlight that.
Thank you very much, Anurag. Hopefully everybody can see my screen.
Yes.
Yes. Okay, so yeah, thank you very much. This is a brief presentation on the development of what we call the RAISE device for gasless surgery. I'm presenting very much on part of the team. You can see the team mentioned here. It's a multidisciplinary project involving engineers like myself and product designers, as well as clinicians, people from industry. Mr. Sandeep is here representing. So it's a really widespread group, and that's something I'll come back to. But perhaps this is an example of how we can work together and the virtues of doing it. So it's been introduced already about the need for gasless surgery. We stepped into this project on the back of some of the work from the Global Health Research Group based in Leeds. And there was an understanding about the needs for improvements in the equipment for gasless surgery. So as part of our development process, right from the onset, we worked really closely with people who understood this in real detail, not just what it has to do surgically, but the environment in which the equipment has to be used. So that has a real impact on how we design the systems. Our goal was to design a lower cost system that was improved in performance, really addressing things like the ability to sterilize and provide a better surgical experience. So we did this by using two principles throughout our design and development process. One's called frugal innovation. So that means we essentially try and keep things as simple as possible. Just keep the solutions to the very core of what they need to do. And the second is about participatory design. So essentially working together as part of this multidisciplinary team, involving the experts, so the surgeons, the healthcare professionals, right from the outset and all the way through the process. That's the key to kind of achieving a design and a system that is going to be useful for people in the future. So you can see some of the development stages we went through there, going from really kind of basic prototypes where we had lots of bits of plastic and 3D printed parts, all the way through to more professional and usable prototypes. And these were produced when we started to work hand in hand with our manufacturing partners. So as we got more developed and as we kind of worked our way through the development process, we were able to attend, I think this was in 2019, the ARSICON conference, so the Rural Surgeons of India, their Rural Surgery Conference, and test some of our prototype systems out. And you can see Millie here as part of the team getting feedback on how those systems perform. We fed that into the design process, really looking to understand what we could do better, what we needed to improve upon. And then the COVID pandemic hit, which was a challenge, but we worked around it. We did some further studies based in Leeds, but you can see some of our team here. So there's Mr. Sundeep, Mr. Tamandeep from XLO, who are our manufacturing partners. You can see our clinical team, Prof. Anurag there, Dr. Lovinish, and people were participating remotely. And again, this feedback was used to kind of inform the next development of the system. And what we were looking to do was not just make this an academic exercise. I work at a university, but we want to see the work have impact in rural settings in the real world. And so that's where it was really essential to work with our partners to commercialize and to make an actual commercially available system. So that's what you can see here. Working with XLO, they actually do orthopedics, but this means that they have the manufacturing expertise to really handle all the manufacturing and get the precision and the tolerance, and they understand medical equipment. So we're able to produce a system that is going through the regulatory process now within India. And our team at MAMSI, Prof. Anurag, Dr. Lovinish, are actually leading the evaluation of this kit now. They've been through a series of workshops with that equipment in patient cases. And what we're looking to do is demonstrate that it works as it's intended, it's robust, and really to provide the evidence so that others can benefit, we hope, from this technology. And we feel like we have, in this process, really lowered the costs, so lowered the barriers to use of this equipment for gasless surgery, and improved the surgical experience in doing so. But the way that we've done this, and these are some of my kind of summary points, kept this very brief, but hopefully we've kind of highlighted here that it's really important to identify a relevant need. So we're not just engineers pursuing some goal that we think is important, and actually it isn't. And we've heard earlier on with some great talks about the need for supporting rural surgery. So we need to identify and target a relevant need. We need a good team of multidisciplinary people who can help develop these things all the way from the outset, all the way through to clinical use. Commercial translation is really important. So as academics, we like to develop new ideas, but if we need to get them into the real world, we need to work hand in hand with industry partners in order to do that and make that available more widely. And last of all, Noel touched on it, it's the importance of supporting new healthcare pathways. So a device like this on its own is no good unless it's supported by training and expertise, and clinical champions, all the kind of surrounding infrastructure, which is exactly why we need to work together as a community rather than kind of in individual pockets. So hopefully that's kind of highlighted some of the work that we've done, both on the device and working as a team. There's longer forms of this information. I'll put some links in the chat thread if you're interested in seeing some of the videos. But in the interest of keeping this to time and having a broader discussion with the panel, I'll end now and just say thank you very much to everyone.
Thank you, Dr. Pete, for that presentation and kind of showing us the steps we are taking in for future. Okay, so that brings us to end of the session 2.